Hello, everyone. My name is Chanu Ri. I am an infectious disease and critical care physician here at the Brigham Women's Hospital, also a sepsis researcher and clinical co-lead for the Quality Improvement Initiative on sepsis across our partners' hospitals. So I'll be talking about sepsis, new definitions and guidelines today, and thank you for joining me on this lecture. I have no financial disclosures. And the outline of the talk will be just a little bit about the epidemiology and burden of sepsis, and then jumping into definitions and diagnosis, and updates to management guidelines. So why all the fuss about sepsis? I feel like this is all over not only the medical literature, but also the lay media. And I think a lot of the fuss is really because of the increasing recognition of the great burden of sepsis in this country and globally. So just in the US alone, the estimates are that there's more than 1 million cases of sepsis per year, the leading cause of death in the ICU, the most expensive condition treated in hospitals. It may contribute to a third or even half of all hospital deaths. And even patients that survive are not out of the woods. They're at high risk for more episodes of sepsis, readmissions, and overall decline in quality of life. So while I think that the medical profession has long realized what a problem sepsis is, the public attention is really, I think, increasing in the past couple of years. And one event that really helped to catalyze this attention was really the tragic death of a 12-year-old boy back in 2012 in New York City who basically died of septic shock. And unfortunately, the symptoms were not initially recognized by the pediatrician or the emergency room where the patient was seen. Essentially, the patient had symptoms of basically what they diagnosed as gastroenteritis. The emergency room missed extreme leukocytosis and band count greater than 50%, sent the patient home, and he returned a couple of days later in fluid septic shock. That seemed to result from a scrape to his elbow or his knee from playing basketball. And in any case, this was a tragic death, obviously. But from this tragedy arose some good in the sense that the family embarked on a nationwide campaign to try to raise awareness of sepsis and prevent as many deaths as they could. And they established the Rory Staunton Foundation, named after the boy who died. And so this really ushered in a new era of policy initiatives for sepsis. So because of this, in New York State, Governor Cuomo mandated sepsis protocols be implemented in all of the hospitals in the state. And this was called Roy's Regulations after the boy. And this has been followed by public reporting and benchmarking for protocol adherence. And now similar measures are being implemented nationwide. Probably most of you are aware that the CMS sepsis measure, the SEP1 measure, took effect now in October 2015. Currently a pay for reporting measure where hospitals need to report their compliance with the 3 and 6 hours bundles for bundles of care for patients diagnosed with sepsis. And we'll go over those bundles a little bit later in this lecture. So with that in mind about the epidemiology and the burden and the regulations now, let's shift into talking about what really is sepsis. It's been described for more than 2,000 years. It clearly refers to a bad infection. That's probably the simplest way to explain it. But I think a lot of us still struggle to really define it. And certainly we can point to some very obvious cases like a patient with meningococcemia or fulminant gram-negative bacteremia. But really those are a minority of cases. To highlight this point and the difficulty in diagnosing sepsis, just want to point out a study that I and my colleagues did a couple years ago where we distributed case vignettes of patients with suspected or confirmed infection and possible organ dysfunction to nearly 100 academic intensivists around the country. This is before the new sepsis 3 definitions, but we asked the respondents to classify the cases whether they thought it was SIRS, sepsis, severe sepsis, septic shock, or none of the above. I'll just highlight one case vignette just to give you a sense of kind of some of the issues that we're talking about. So the first case that we did in this study was a 67-year-old patient with severe heart failure, who came in with several days of shortness of breath, swelling, malaise, cough, and fevers at home. Had a low-grade temperature in the emergency room, rapid atrial fibrillation, hypotensive with signs of volume overload, labs showing elevated white blood cell count, lactate, and acute kidney injury. And a chest X-ray was in pulmonary edema and kind of this classic possible infiltrate clinical correlation advised. And the patient gets fluids, calcium channel blockers to slow his heart rate, and antibiotics, and subsequently gets worse into respiratory failure, shock, and altered mental status, needs to be intubated and put on vasopressors. Gets admitted to the ICU where he's basically treated with everything, vasopressors, antibiotics, antiarrhythmics, eventually gets diuresed when for signs of volume overload. And basically, some combination of those things makes him better, and he gets extubated. All of his cultures are negative, and the clinicians empirically just finish a course of antibiotics, and he eventually gets discharged. And I think the question is this sepsis? This is what we asked the intensivist. And you can see that there was a wide spread of the answers. So more than a third of patients said, yeah, this is septic shock. But actually, almost a third of patients said, no, this is not infectious at all, not even SIRS or sepsis. This is all heart failure. And then some patients said some of the respondents said severe sepsis and sepsis. So you can see there's a wide distribution here. And I think this really highlights, obviously this is a little bit maybe of a cherry-picked example, but I think at the same time not a completely unfamiliar scenario. And I think it highlights again these challenges, because sepsis is a complex syndrome really without a pathological gold standard. So as in this case, it's often unclear if a patient is infected or not, certainly up front. And even in retrospect, a lot of times we're not totally sure the patient actually had an infection or not. Defining organ dysfunction can be a little bit subjective as well. The thresholds are not always well defined. And then if the patient does have organ dysfunction or other physiological derangements, determining whether that's due to infection versus other causes is really hard and subjective. And so this really emphasizes again that sepsis really has no true gold standard. Even expert clinicians disagree, sometimes very often, as to who has sepsis. And that begs the question, why should we even try to define sepsis in the first place if it's so difficult? And I think with those caveats in mind, I would posit that the definitions are really clinical criteria that are meant to aid clinicians. So the purpose being that if we call a patient as sepsis rather than pneumonia or urinary tract infection, it really helps to identify the patients who are at a high risk of having bad outcomes, in whom early and timely interventions can improve outcomes. I think that's really the crux of labeling patients as having sepsis. I think certainly there's other benefits to defining sepsis in terms of understanding its epidemiology, tracking outcomes and quality of care, as is trying to be done with the CMS SEP measure, and of course defining criteria for clinical studies. But I think, again, I would argue that trying to help clinicians at the bedside is really the primary goal. With that, I want to talk a little about the history of sepsis definitions. And I guess I'll take us back now to 1991. This was the first consensus conference between the American College of Chest Physicians and the Society of Critical Care Medicine. And I'll just say prior to this, a lot of these terms of sepsis, sepsis syndrome, septicemia, septic shock, they were being used a lot in the literature, but with really no clear standardization. And this was the first attempt to try to standardize it. So conceptually, sepsis was defined as the systemic inflammatory response to the presence of infection. And this is where the SIRS criteria that we all know and love was first defined, and really just defined by expert consensus opinion, where two or more of elevated temperature or hypothermia, heart rate greater than 90, respiratory rate greater than 20, elevated white blood cell count or low white blood cell count or elevated bands, with sepsis being infection with SIRS, severe sepsis being sepsis with organ dysfunction, and septic shock being basically sepsis with refractory hypotension. So this was a framework that's been in place for more than 20 years, and this was the kind of a Venn diagram that came out around that time, showing the intersection of infection on the left with SIRS, and kind of the in-between there being sepsis, with things like bacteremia and fungemia, other types of infections, some of them crossing over to sepsis, but not all of them, and then also highlighting the other many non-infectious causes of SIRS like trauma, burns, and pancreatitis. So about 10 years later, in 2001, Sepsis 2 was convened. Now a couple more professional societies got involved in this conference. And while they expanded the list of diagnostic criteria, there was really no other significant change to this framework. And in this document, if you look closely, they have this table 1, which is kind of, I would say, infamous in the sense that it's this long, expansive list of potential diagnostic criteria for sepsis. But look at this. I would say this is not particularly useful. They have more than almost 24 variables here: fever, hypothermia, heart rate, tachypnea, altered mental status, edema, hyperglycemia, blah, blah, blah. And while expanded kind of, tried to emphasize that sepsis can have a wide range of symptoms, I would argue that this was not particularly helpful in really nailing down who has sepsis, who doesn't have sepsis. And despite this table, really, again, the SIRS, severe sepsis, septic shock framework was really not changed. Just briefly, the Surviving Sepsis Campaign guidelines in 2012, it wasn't a definitions conference, but it was actually the first time that they offered some operational criteria and cutoffs for organ dysfunction. So things like urine output less than 0.5 mg per kg per hour for more than 2 hours, acute lung injury with p-to-f ratio less than 250 in the absence of pneumonia or less than 200 in the presence of pneumonia, creatinine greater than 2, bilirubin greater than 2, platelet count less than 100, INR greater than 1.5. And these are actually the cutoffs that were adapted into the current CMS definition of severe sepsis that they use in the STEP 1 measure. So while it's nice to have some concrete thresholds, there's really no guidelines here on how to interpret pre-existing organ dysfunction. So a patient has infection and their baseline creatinine is 1.9, and now their creatinine is 2.1. Does that count, or does it have to be some sort of significant change from baseline? Really vague and not clear how to interpret that. Okay, so jumping into the Sepsis 3 definitions. This is published now in JAMA in February 2016. And this, I will say, this was obviously a big paper, got a lot of press, continues to generate a lot of discussion. And so why did this group decide to do a new definition? So I think there's been an increase in recognition that the SIRS criteria are problematic. So they're obviously nonspecific for infection and sepsis. And while it's thought to be quite sensitive, there's some evidence showing that it actually misses some cases of infection and organ dysfunction as well. And so it's not perfectly sensitive. And from a pathobiological standpoint, sepsis is now felt to be a dysregulated inflammatory response to infection. But SIRS is actually physiologic. If you think about it having a fever and elevated heart rate in response to an infection, those are normal adaptive responses. And actually, it's organ dysfunction is what crosses the line between adaptive and maladaptive. The term severe sepsis is felt to be confusing. Many clinicians use sepsis and severe sepsis interchangeably. So in the sense that when clinicians point to their patient and say, this patient is getting septic, they're usually talking about hypotension or organ dysfunction rather than a fever and a heart rate of 91, for example. And getting to this issue of these poorly defined thresholds for organ dysfunction and septic shock, it's led to a lot of heterogeneity in study cohorts. And the Sepsis 3 task force also felt that septic shock is not just sepsis with hypotension or cardiovascular dysfunction, it's more than that. So this was a paper from the Australia and New England Critical Care Group looking at patients that were admitted to the ICU who had infection and organ dysfunction. And you can see that while SIRS was pretty sensitive, 88%, about 12% of the patients did not have SIRS. And on the right here, that certainly while more SIRS criteria leads to higher chance of mortality, there's no magical step function that happens between, at 2 SIRS criteria. And arguing that this kind of 2 SIRS criteria is basically arbitrary. The incidence of SIRS in ward patients, this is a paper from Matt Cherpek in the Blue Journal, where it basically showed that after a week in the hospital, 3/4 of all patients met SIRS criteria in hospital wards and non-ICU patients. and really emphasizing that SIRS is so prevalent that its utility as kind of a screening tool for sepsis is limited because of that. This is a meta-analysis that was included in the Sepsis-3 set of articles where they did a meta-analysis of 44 studies of septic shock and looked at the wide range in mortality. You can see that some studies showed a mortality of 20% and some of them up to 80%. And I think the argument is that maybe some of this is due to differences in care, but probably most of it is just due to different study entry criteria and definitions. So the major conceptual changes in Sepsis-3 is that sepsis is defined as now as a life-threatening organ dysfunction caused by a dysregulated host response to infection. Septic shock defined as the subset of sepsis in which there's particularly profound circulatory, cellular, and metabolic abnormalities that are associated with a greater risk of mortality than with sepsis alone. So practically speaking, SIRS criteria has been removed from the definition. Severe sepsis is removed as well. And basically that is now, what was previously called severe sepsis is now sepsis, infection with organ dysfunction. And septic shock has a more stringent definition requiring both refractory hypotension and elevated lactate as a marker of cellular and metabolic abnormalities. And the big, one of the big changes in Sepsis-3, or one of the big advances, I guess, was the introduction of the concept of quick SOFA. And let's talk about that. In terms of the operational criteria for Sepsis-3. So they said, okay, all right, so sepsis is infection organ dysfunction. So then how do you define organ dysfunction? They decided to go with what's called the SOFA score, the Sequential Organ Failure Assessment Score. And they said that's going to be a rise in the SOFA score by 2 or more from baseline associated with infection. That should be called sepsis. And this quick SOFA was introduced as two or more of the 3 criteria being respiratory rate greater than 22, altered mental status, and systolic blood pressure less than 100. And septic shock being infection plus vasopressor-dependent hypotension plus lactate greater than 2 in the absence of hypovolemia. So the SOFA score was created really by expert consensus opinion in 1996. And it defines organ dysfunction in 6 domains. So respiratory with the P-to-F ratio, coagulation with the platelets, liver with bilirubin, cardiovascular with the blood pressure, mental status neurological dysfunction through the Glasgow Coma Scale, and renal dysfunction through creatinine and or urine output. And you can see that each of them you can get 0 to 4 points, so a maximum of 24 points on the SOFA score. So where did this being the Sepsis-3 criteria come from? So as opposed to prior definitions that were really based on expert opinion, the Sepsis-3 task force wanted to use EHR data sets to try to lend more evidence or validation to their criteria. And the primary data set was a large EHR data set from the UPMC system, more than 1 million encounters, and they identified patients with suspected infection, and they defined that with patients that had a clinical culture and administration of non-prophylactic antibiotics. And they compared various sets of criteria for the ability to predict in-hospital mortality, prolonged ICU stay, or both. And I actually like this rationale that they said, there, again, as we talked about, there's no gold standard for sepsis, right? But bad outcomes like a long ICU stay or death are going to be more likely amongst patients who have sepsis than uncomplicated infection. I think that's a reasonable starting point for this analysis. So they took 21 bedside and laboratory criteria from Sepsis-2. You recall that table, that infamous table 1 I showed you with almost 24 various signs and symptoms, and they took as many of those as they could operationalize into a multivariate electronic analysis to try to identify parsimonious criteria that had good predictive ability for either death or prolonged ICU stay amongst the patients with suspected infection. And they found that hypotension less than 100, respiratory rate greater than 22, or Glasgow Coma Scale 13 or less performed as well as and more complicated models, basically. And even when you recoded the Glasgow-Coma scale as less than 15, therefore any alteration of mental status, the performance was basically the same. And this was robust to different sensitivity analyses. Interestingly, adding lactate at different cutoffs didn't really seem to improve the predictive ability. And so they settled on these three very simple bedside measures into their criteria that they call quick SOFA. This is just a graph. It looks a little bit complicated, but it's basically showing the predictive ability for hospital mortality for SIRS versus SOFA versus LODS. LODS is a logistic organ dysfunction score, just basically another organ dysfunction score that's a little bit more complicated than the SOFA score, and versus quick SOFA. And they looked at it inside the ICU and outside the ICU. And basically, you can see that quick SOFA here, so outside the ICU, it performed better than SIRS and pretty much comparable to the full SOFA score and the LOD score. And within the ICU, SOFA score and LODs were actually a little bit better. And they validated these findings in several external data sets. So, in summary, quick SOFA, they posited that it's simple, easy to apply at the bedside. I think that's difficult to argue. You can't argue with that. And that in patients with suspected infection, it identifies a subset of patients who are at high risk for poor outcomes. SIRS has relatively worse predictive and discriminatory power. And SOFA score and the LODS score performed similarly and was better than either the quick SOFA or the SIRS in the ICU. And the task force went with the SOFA score just because it's a little bit simpler and more familiar within the ICU community. Just talk really quickly about the septic shock derivation. This was a separate paper within that, within the same JAMA issue. Basically, the task force determined amongst themselves that there are three variables that are relevant for septic shock: hypotension, vasopressor requirement, elevated lactate. And they basically looked at the Surviving Sepsis Campaign database to look at these different combinations of these variables and their correlation with mortality and their prevalence. And it's not rocket science. Basically, if you have hypotension after fluids and you require vasopressors and your lactate is greater than 2, you're going to have the worst outcomes than any other combination of that. For example, if you're hypotensive and require vasopressors, but your lactate is normal, then your mortality is going to be a little bit less. And that's exactly what they found here. So that first group here, all three of them, it's both pretty prevalent in the severe sepsis septic shock cohort and had a mortality of 42%, which is higher than all other combinations. So not rocket science, but it was kind of a nice, simple demonstration that all three of these variables are important and kind of identify really the sickest of the sick among septic patients. So a little bit more about definitions. So this is a severe sepsis definition in CMS that's used for the SEP1 measure that's really based on the traditional sepsis criteria. It requires documented or suspected infection, 2 or more SIRS criteria, and these type of organ dysfunctions are attributable to infection. And I've highlighted the ones in red that are kind of removed from sepsis 3. So SIRS is no longer part of sepsis 3. Lactate is not technically part of the SOFA score, so it's not part of the sepsis 3 definition. And the INR PTT criteria doesn't factor in anymore. And the Glasgow-Coma scale is incorporated into the definition in terms of the neurological component of the SOFA score. And all these other components are really part of the SOFA score. So that's kind of a quick illustration of how these definitions differ a little bit. The CMS definition of septic shock, which is really the definition that's been used in all the early goal-directed therapy trials of septic shock, which is infection or suspected infection with persistent hypotension after fluids or a lactate greater than 4, now requires vasopressors and a serum lactate greater than 2 after fluid resuscitation. So really, this is a sicker definition, or it's honing in on the sickest subset of septic shock patients. This is another kind of updated Venn diagram showing the conceptual changes in sepsis 3. So with sepsis 1 and 2, again, same thing here. Infection on the left with the intersection of SIRS, and you get sepsis. And within this sepsis circle, you have severe sepsis and septic shock. And again, all these non infectious causes of SIRS. With sepsis 3, the infection oval, I guess, stays the same size. Now, SIRS is not really a part of it, but really it's organ dysfunction. It's the intersection of organ dysfunction and infection that leads to sepsis. And we purposely made this circle smaller than the sepsis circle in sepsis 1 and 2, because sepsis here is really more the approximation of the prior severe sepsis. And similarly, the septic shock circle here in sepsis 3 in the lower pane is smaller than the prior septic shock circle because, again, it's honing in on the sickest subset of sepsis patients. And again, with organ dysfunction, you have all these other things that really that can cause organ dysfunction that are non-infectious in etiology, like stroke, heart failure, hypovolemia, et cetera. Some of the Sepsis 3 task force members released this paper, just kind of try to clarify that QSOFA, there's a lot of misconception, I think, that the QSOFAs are replacing SIRS, and that's not really the case. So again, in the prior definition, you really had to have SIRS and infection to have sepsis, whereas here in the new definition, QuickSOFA, you can see it's not required. It's most of those patients, I think this circle and the intersection of the infection is highlighting that most of them will probably have sepsis, but not everybody with infection QuickSOFA actually has sepsis. So it's not a strict replacement for SIRS. So the new suggested approach to identifying patients with sepsis and septic shock is as follows. Patients with suspected infection, you can very quickly assess their QuickSOFA score. If it's greater than 2 or more, you should be worried and you should assess for evidence of organ dysfunction. Get all the full gamut of labs to assess the SOFA score, and if it's 2 or more or greater than a rise of 2 or more from baseline, then the patient should be designated as having sepsis and treated as such. If after fluid resuscitation they're requiring vasopressors and have an elevated lactate, then they have septic shock and their chance of mortality is very, very high. That being said, QuickSOFA is not a perfectly sensitive screen, so even if your QuickSOFA score is not 2 or more, depending on your clinical suspicion, if you still suspect sepsis, then you should proceed down the same pathway and assess for organ dysfunction and manage them as such. And if not, continue to monitor and reassess if clinically indicated. So maybe this graph makes a little bit more, this figure makes it a little more complicated than it is, but not a bad framework. I think that really the most important takeaway, at least that I took from the Sepsis 3 document, was if there's suspected infection, you should always look closely for signs of organ dysfunction. Conversely, if a patient has unexplained organ dysfunction, you should assess for infection. I think that's a pretty good rule of thumb to take away from Sepsis 3. Okay, the Surviving Sepsis campaign. So they responded to Sepsis 3 and said, this is nice, we like it a lot. That being said, our approach should not, because there was a lot of confusion about how these new definitions would play into the Surviving Sepsis campaign's guidelines. They basically said that their approach should be no different than before. Step 1 is still to screen for infection, and SIRS might be a sign of infection. Then screen for organ dysfunction, and they said if there is organ dysfunction, and in their view, including an elevated lactate, then the 3-hour bundle of care should be initiated. If the QuickSOFA criteria met, then clinicians should strongly consider closer monitoring. And the patient's hypotensive or have an elevated lactate, then they should get fluid resuscitated with close reassessment of volume responsiveness or tissue perfusion. So basically they're saying, look, these definitions, they seem like a big deal, but the core of the matter is the same. Infection, organ dysfunction, and rapid resuscitation. So we'll talk a little bit about the strengths and the benefits of the new definition. So I think the strengths, one of the strengths is that the nomenclature, I think, is simpler. And again, this confusion of severe sepsis versus sepsis, I think it's nice that it reflects what clinicians generally have been saying. It's good that it is data-driven in large part rather than purely expert opinion, although certainly expert opinion had to play a role in the new definitions as well. I think the hope is that eliminating SIRS may help clinical discrimination in the sense that it can guide clinicians to pay more attention to organ dysfunction. It also reflects, again, more nuanced and updated view of the pathobiology of organ dysfunction, distinguishing sepsis from uncomplicated infection. My hope as an infectious disease doctor is that maybe this could decrease broad spectrum antibiotic utilization for SIRS alone. In my experience, I feel like over the past, 10 years or so, it's become very common where reaction from the residents I get is that if this patient has SIRS, therefore I'm going to give them vancomycin and zosyn. And while certainly that is indicated sometimes, a lot of times it's not. And hopefully we can try to have a more nuanced approach to patients with suspected sepsis, rather than using such a overly sensitive and non-specific criteria like SIRS. And I think importantly, again, these kind of tighter definitions of sepsis and septic shock may allow better comparisons of cohorts across time and place. All right, that being said, I think there's certainly limitations, and there have been a number of criticisms that have been published, in fact. Here's some from CHEST saying a change we should not make, and one in the, I believe in the Blue Journal. Anyway, so there's been some criticisms about the new criteria. As you can imagine, it's a big deal. Sepsis is a big deal to a lot of people around the world, a lot of clinicians, and changing the definitions is bound to be fraught with some controversy and strong opinions. So I think the biggest criticisms really center around the concern that the new definitions, by eliminating SIRS and focusing on organ dysfunction and quick SOFA, we're going to delay early identification and treatment, in the sense that the whole idea of SIRS is to catch them. Yes, it's overly sensitive and not specific, but you capture these patients at an earlier stage before they progress to organ dysfunction. And once you're just focused on quick SOFA and SOFA, those patients are already pretty sick, and you've kind of lost your window of opportunity. So that's one big argument. Another one, I would say, this is kind of my own argument actually, that the new septic shock definition, while it might be helpful for prognostic and epidemiological purposes, I don't think it's actually as helpful for clinical management. So the prior septic shock definition of persistent hypotension after fluids or lactate greater than 4, I thought that had a lot of important immediate clinical implications. So you knew that patient needed to be, for example, fluid resuscitated heavily if they had elevated lactate, or they need to have timely initiation of vasopressors. Whereas the new definition, they're already on vasopressors, they have an elevated lactate. Yeah, they have a very high chance of death, but what else are you really going to do at that point? Or there's less implications for the immediate clinical management. And overall, I think there's been concerns that these changes may reverse decades of quality improvement efforts with the old definitions. The argument has been that, look, we've made progress. Clinicians, hospitals, nurses have learned these old definitions. We've improved outcomes. Why change course now? I think also criticism has been around the SOFA score. It was really initially created for ICU research. And at least myself as a clinician, I don't usually think that much in terms of scores. So trying to calculate a score for every patient that goes from 0 to 24, and something like the SOFA score, which is not easy to memorize, I think that can be problematic from the standpoint of bedside clinicians. And again, the SOFA score was created in 1996, so some of the aspects are outdated, like the vasopressor scoring. There's no mention of vasopressin or neosynephrine. There's an emphasis on dobutamine, which is used less frequently now for sepsis. For the P to F ratios, we're not always getting arterial blood gases on our patients. We're relying a lot more on venous blood gases, for example. And some aspects of the SOFA are ICU specific or not routinely measured, like the Glasgow Coma scale, really not often measured in floor patients. And things like the vasopressor doses or P to F ratios. So that's one limitation. I think the other big limitations are that really there's no guidance on identifying infection. And while they probably wisely stayed away from that, the Sepsis 3 Task Force said, that's such a big topic that we're not even going to go there. That really is oftentimes the biggest challenge in identifying sepsis, right? Trying to figure out if our patients are infected or not. Similarly, the new definitions don't really make a comment or any guidance in determining whether an organ dysfunction is caused by infection versus some other cause. So that subjectivity that I talked about earlier in the lecture I think that's likely to persist. I would say septic shock. I think a lot of patients have shock and organ dysfunction but never express a lactate. And to me, I still say, that patient has septic shock, no matter what the sepsis 3 definition says. Doesn't yet apply to pediatrics, although efforts are underway kind of to try to revamp sepsis definitions in kids. And they're at odds with the CMS sepsis measure. And CMS has said, we don't have any particular problem with these new definitions, but we just don't have any plans to change our criteria. We'd like to see more data about the utility of these definitions before going down that route. So a couple unresolved issues. Is there still a role for SIRS criteria? I think this is kind of an ongoing debate. And the argument for SIRS criteria is that while the analysis of the data sets and their derivation showed that SIRS was not as predictive as QSOFA, it was still moderately predictive of adverse outcomes. It wasn't useless. And other studies have shown that there's a stepwise increase in mortality with increasing number of SIRS. And just having SIRS with infection carries a non-significant mortality rate, 7% or more in some studies. And that SIRS plus infection progresses to organ dysfunction in more than half of cases. So again, making the argument that SIRS might be useful to try to catch sepsis in the early phases. And so I think a lot of us think that while it may not define sepsis anymore, that the continued use of SIRS as at least part of a screening tool for potentially infected patients seems reasonable. Is QuickSOFA the best screening tool? So again, they showed that it had good predictive ability and discrimination for poor outcomes, but some new studies are showing that it's not particularly sensitive for detecting the whole gamut of organ dysfunction, and that, in fact, other established warning tools like the Muse and the NEWS scores appear to be better actually at predicting mortality and or prolonged ICU stay amongst potentially infected patients in QuickSOFA. And that SIRS criteria, again, are met earlier in hospitalization than QuickSOFA amongst these patients that end up having bad outcomes. And so I guess I would say the jury's still out. I think really we need prospective studies comparing different early warning tools and ideally how they impact clinical outcomes when used in clinical practice. I think we really need those to try to figure out what's the best way of screening for sepsis. I'll just say that, again, nothing new has been offered in terms of diagnosing infections. So I think, again, that's the biggest challenge for a lot of us. So I think the site-specific cultures and diagnostic tests, things like procalcitonin can be imperfect but potentially useful. And again, emphasizing that this is challenging because up to half of sepsis cases actually never have an organism identified. All right, so I'm going to jump ship into the last part of this talk about some updates to management guidelines. So recently, the Surviving Sepsis Campaign released their latest iteration of their management guidelines, the 2016 version. What's new in 2016 versus the 2012 guidelines? They've basically been releasing this every 4 years, 2004, 2008, 2012, 2016. And after reading this document, I came away saying, the general principles of sepsis management are really unchanged. Early identification, treatment with appropriate antibiotics, fluids when there's hypotension or hyperperfusion. That's really the key, as well as source control. I think the major change that all of us knew was coming is that early goal-directed therapy, as kind of the dogma of sepsis management, has really fallen out of favor. And I'll summarize those trials briefly at the end of this talk. Rapid fluid resuscitation with 30 cc's per kg within 3 hours of hypotension or hyperperfusion, that's still in, but rather than using kind of these set CVP goals, for example, or SCVO2 goals, additional fluid should be really guided by frequent reassessments, and ideally with a preference for dynamic measures of hemodynamic status, like passive leg raise and bedside ultrasound, over the static CVP measures, for example, to predict fluid responsiveness. This is the CMS sepsis measure, and really it's drawn very closely from the Surviving Sepsis Campaign guidelines. And really the emphasis here is that time is of the essence. So within 3 hours, the government is telling us that we need to measure a lactate level for patients with severe sepsis, get blood cultures prior to antibiotics, administer broad-spectrum antibiotics, and if they're hypotensive, to give 30 cc's per kg of actual body weight of normal saline or lactated ringers. Within 6 hours to remeasure the lactate if the initial lactate is elevated, greater than 2. And if you have septic shock with persistent hypotension, to administer vasopressors and perform a repeat volume status and tissue perfusion assessment. Not part of the measure, but of course, which is really important, is the issue of source control, such as drainage of an infected abscess or removal of an obviously infected central line, for example. The two highlighted here, this number 5 and 7, are ones, at least at our own hospitals, that we've had a lot of trouble with complying with, or rather are a frequent cause of non-compliance. And I think we and probably many other hospitals around the country are trying to struggle with how to maximize the compliance with this measure. So even though the CMS measure says 3 hours for broad-spectrum antibiotics, 1 hour is actually recommended by the Surviving Sepsis Campaign. That being said, logistically, that can be very challenging. So I think the bottom line is the faster the better that you can get. The faster you can get the antibiotics into the patient with sepsis, the better. Why check lactate? So it can identify tissue hyperperfusion, often before overt hypotension. Clearly, there's a lot of prognostic significance of the lactates, both the initial level and lactate clearance. And that early rapid lactate testing may actually improve patient outcomes, some evidence of that. I'll just skip over this and just say briefly that everybody knows that early antibiotics in sepsis are important, with every hour delay in septic shock being associated with a decrease in survival. And this was Kumar's Sentinel retrospective observational trial in 2006 that was the first big study to show this. I'll just mention that appropriate antibiotics really depends on the site of infection and the risk of multi-drug resistant organisms. The one thing we've been really emphasizing at our hospitals is that for the most part, the broad-spectrum beta-lactam is going to be the backbone of your therapy. And really, things like vancomycin, and certainly things like Flagyl or antifungals really are rarely the priority. But I tell the residents and some of the nurses that if you have one IV access only and you're trying to choose your antibiotics, do not do the Flagyl. The Flagyls rarely save the day for a patient with sepsis. The broad-spectrum beta-lactams are really the key. I'll just say about the fluids. So while the CMS measure says 30 cc's per kg, if you're hypotensive or have a lactate greater than 4, that's fine. But I think the days where we're flooding patients with 10, 12 liters of fluids within the first couple hours, the first 24 hours, I think we're starting to back off a little bit, because there's increasing evidence about the downsides of over-resuscitation in a positive fluid balance. And remember that sepsis is primarily a vasoplegic state, and while there's certainly some sort of hypovolemic component early on, really at some point they just need vasopressors to maintain their blood pressure. And there's a number of articles kind of underscoring the downside of a positive fluid balance. Really, that emphasizing that frequent reassessment is critical, rather than just having kind of a single amount of fluid that you're going to give, to really tailor to the patient based on a constellation of signs and symptoms. Okay, and the choice of fluids, really the whole debate of colloids versus crystalloids has been ongoing. Really no obvious benefit to colloids has ever been borne out, and thus isotonic being fine for the most part, but caution with large volumes of normal saline due to the hypochloremic metabolic acidosis, hypernatremia, and possible risk of acute kidney injury. That's supposed to say possible higher risk of acute kidney injury. So in practice, what I and a lot of my colleagues will do is maybe after the first 2 liters normal saline, we'll usually switch to lactated ringers. All right, and I'm going to skip over the vasopressor, just saying that norepinephrine has really emerged as a clear first-line vasopressor for most patients with septic shock. All right, and I'm going to finish by talking briefly about the demise of early goal-directed therapy. Everybody knows Rivers' Sentinel trial in 2001 in the New England Journal of Medicine, where they used this protocol targeting specific CVP goals, MAP goals, SCVO2 goals, with fluids, vasopressors, and transfusions and inotrops if needed, showed a significant mortality reduction. There have always been questions about that study in the sense that it was a single center study, it was relatively small, and unclear which parts of the protocol were really important. And the question came up in the current era, is the entire protocol really still necessary? And I think the answer to that is a resounding no. There's now 3 multinational trials that all showed no difference in outcomes with early goal-directed therapy versus usual care. And I'll just say, why no benefit to early goal-directed therapy? I think theory number 1 was that the original Rivers trial was just a fluke, perhaps. The second theory is that the patients were sicker in the Rivers cohort, but they were, even in the sickest subset of patients in the new trial, there was no benefit. And theory number 3, which I really like, is that usual care has improved since the pre-Rivers era. So the Rivers trial really ushered in a new kind of mentality and approach to sepsis of really kind of aggressive care. And I think this concept of early aggressive therapy is really now ingrained in clinicians. You can see that in the 3 new early goal-directed therapy trials, most of the patients had received antibiotics very quickly, and as well as fluids. And I think really emphasizing that early recognition and treatment with antibiotics and fluids are the key, whereas things like routine CVP and SCVO2 monitoring are not going to be necessary in all patients. Okay, so summary and take-home points. In terms of the epidemiology, sepsis is a major problem, major cause of morbidity and mortality, and I think now, rightfully so, is the focus of national quality measures. But I've tried to emphasize that really accurately tracking sepsis rates and outcomes, in part due to the subjectivity in diagnosing sepsis, is really challenging. The new definitions shift the emphasis away from SIRS and towards quick SOFA and organ dysfunction. That being said, while there's been a lot of positive press about them, they've also not been universally embraced, and there's concerns about whether these new criteria will actually delay the early identification and treatment of serious infections. And no matter how you define exactly the sepsis criteria, identifying infection is really, I think, the biggest challenge still. And in terms of management, early recognition and appropriate antibiotics and resuscitation are still the key. And however, probably too much fluids may be harmful, and we're kind of shifting away from the massive resuscitation and towards earlier vasopressors, and that's in fact actually what the CMS SEP measure emphasizes as well. And clearly that strict adherence to the early goal-directed therapy is not needed. More of an emphasis now on frequent reassessments using static and preferably dynamic measures of fluid responsiveness. So that's the end of my lecture, but I will conclude with 2, board-style questions to just reinforce some of the concepts that we talked about. So question 1, which of the following is false regarding the new sepsis 3 definitions? A, sepsis-associated organ dysfunction can be quantified by a rise in the SOFA score by 2 or more from baseline. B, septic shock is defined as infection leading to persistent hypotension requiring vasopressors and an elevated lactate of 2 or more, in the after fluid resuscitation is what that should say. C, the systemic inflammatory response syndrome criteria are no longer part of the definition of sepsis. D, the quick SOFA criteria replace SIRS in the new definition of sepsis. E, the quick SOFA criteria were developed and validated in large EHR data sets based on the ability to predict death and or prolonged ICU stay in patients with suspected infection. So which of the following is false? And the answer is D. So all of those statements are true except for D. And what I was trying to highlight here again is this misconception from a lot of people that quick SOFA is kind of the new SIRS, and again, that's not true. Quick SOFA was meant to serve as a simple and efficient prompt for patients who are at high risk for adverse outcomes. But unlike the prior SIRS sepsis criteria, not all patients with sepsis will meet quick SOFA criteria, so they're not exactly the same. Their purpose is a little bit different. Question 2, a 65-year-old female with diabetes, hypertension, and kidney stones who weighs 80 kilograms presents to the emergency department with several days of fevers, flank pain, dysuria, and malaise. She is tachycardic, confused, tachypneic, and hypotensive, With a blood pressure of 70/40, the initial lactate is 2.5. She's given ceftriaxone after blood cultures within 3 hours. She's bolused with 2 liters of normal saline within 2 hours with some improvement, but after 1 hour after finishing her second fluid bolus, she becomes hypotensive again to 70/40. So which of the following is true in regards to her care and the CMS SEP1 measure? A, to pass the SEP1 measure, she should be started on vasopressors within 3 hours of her recurrent hypotension. B, the amount of fluid she received is inadequate to pass the SEP1 measure. C, her care fails the SEP1 measure because antibiotics were not given within 1 hour of sepsis presentation. D, she does not meet severe sepsis criteria for the SEP1 measure. E, based on her initial lactate level, a repeat lactate level is not required. So go through each of these answers. The actual right answer is B, but I'll start with A. To pass the SEP1 measure, she should be started on vasopressors within 3 hours of recurrent hypotension. So that's false because the SEP1 measure requires vasopressors within 6 hours of recurrent hypotension or septic shock. C, her care fails the SEP1 measure because antibiotics were not given within 1 hour. That's false. The SEP1 measure requires antibiotics to be given within 3 hours. Although, again, recall that the Surviving Sepsis campaign recommends that, if possible, to give it within 1 hour. D, she does not meet severe sepsis criteria for the SEP1 measure. That's false. She has basically all the criteria: SIRS, infection, and organ dysfunction based on her hypotension and elevated lactate. Based on her initial lactate level E, repeat lactate level is not required. That's false. A repeat lactate is required within 6 hours of the initial lactate is greater than 2, and hers was 2.5, I believe. Yep. And the right answer is B. The amount of fluid she received is inadequate to pass the SEP1 measure because the SEP1 measure requires 30 cc's per kg of fluids within 3 hours of sepsis-associated hypotension. Because she weighs 80 kilograms, she would have required 2.4 liters, and in this scenario, she got only 2 liters. So that's the right answer in this case.